Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
October is Breast Cancer Awareness Month, and during this month, we recognize the ongoing challenges and very substantial breakthroughs in breast cancer care. Tonight on Yale Cancer Answers, we're focusing on what can be an overlooked aspect of cancer care, and that is the financial challenges that many patients face during their treatment and potentially can limit some of the progress that we've made. Our guest is Dr. Rachel Greenup, who is Chief of Breast Surgery at Yale School of Medicine in the Department of Surgery. She is a professor of surgery and a leader in breast cancer research. Her recent work, which is funded by our federal government, is focused on financial toxicity, and she will describe more about that. Rachel is passionate about supporting patients with economic challenges, particularly when these economic challenges affect our ability to provide optimal care. Rachel, thanks so much for being here with us tonight on Yale Cancer Answers.
Thanks for having me, Eric.
I sort of like to begin with a little question about sort of what brought you here and doing this. But, what led you to become a surgeon and in particular a breast surgeon?
So I was raised by two physicians, two academic physicians. My mother was an academic nephrologist. My late father was an academic transplant surgeon. They loved their work. People asked me if I was pressured to become a doctor, and the answer is no. I saw how happy they were and how fulfilled they were in caring for others, and it was really contagious. I swore I would never become a surgeon like my father, but when I got into the operating room, I got bit by the bug. And breast cancer surgery is a really unique opportunity to have long-term relationships with patients and their families, to help them at a really scary time make critical decisions to remove their disease, and then to see them healthy on the other side again. And I can't think of many professions that provide that incredible relationship or ability to serve people in such a deep way.
Well, I will tell you, I think, as you know, that I feel similarly, and it is truly a very rewarding field. Maybe we can just jump right into financial toxicity. And, it's a term that I think many of our listeners may not be incredibly familiar with. I think they can probably figure out in one way or another what it means. But tell us a little bit about how you would define financial toxicity.
So the term financial toxicity was actually first introduced into the literature in 2013 by my colleague and friend Yusuf Zafar, who was faculty in medical oncology at Duke University at the time. And it really was introduced to acknowledge and describe the severe emotional stress that patients and families experience when going through cancer treatment. We recognize side effects of cancer treatment such as numbness, hair loss, scars after surgery, but we weren't acknowledging the financial ramifications of a major medical illness. And medical illness is still the leading cause of bankruptcy in the United States. And bringing the term financial toxicity to the forefront really gave patients, families, and the academic and community oncologists an opportunity to come together to study and begin to address this issue.
And it's not just a matter of not being able to pay a bill. It's all the emotional angst that can come with that, which can range from sort of mild anxiety to real depression at times. I mean, I can tell you that as somebody who can pay my bills, that I get bills from the hospital and bills from various places, and I look at them and I say, but I thought I met my deductible. And, it feels like there's this endless bureaucracy around all of this, so that even for somebody who's connected and well off, it's anxiety provoking, let alone somebody who doesn't have resources.
That's correct. So there are different categories of financial toxicity, which is also known as financial hardship. There's the direct costs, which are the bills to pay for medical treatment. There are the indirect costs, which are missed opportunities to earn money when you're taking time off of work to receive treatment. And people who have been diagnosed with cancer know that receiving treatment, being in the hospital, waiting for chemotherapy infusions is practically a full-time job. And then there are really hidden costs that patients describe that we do less to intervene upon, things such as wigs for chemotherapy-related hair loss, post-mastectomy bras, physical therapy appointments, bandages for wounds and dressings, parking, gas to and from the hospital. It definitely adds up.
It just adds up hugely. And then, for that matter, all the meals you might buy when you're waiting for your visits that otherwise you would eat at home. And, oftentimes this doesn't just involve a patient. It involves a family member or a friend as well. So other people potentially aren't earning a wage from their job or having to take, sick days or personal days off. And it hugely mounts up. So how common is this problem? I mean, in a sense, you could imagine it affects everyone to some degree, but in terms of causing real distress or interfering with care, are there estimates about how frequently that occurs?
Yeah, so initially financial toxicity was described as a quality of life issue, which it certainly is. And the literature says that 50 to upwards of 75% of individuals with cancer have some element of financial hardship related to their diagnosis. About 40% of insured individuals report difficulty paying for their deductibles. About 25% report having to tap into savings to pay for care. The landmark study by Scott Ramsey, which was published again in 2013, was key in getting people's attention in that it showed a clear risk of mortality when people faced bankruptcy after cancer. And so certainly the stress of not affording bills can reduce longevity or survival following any cancer diagnosis. There's also great data that shows that when people can't afford their care, they skip treatments. Even $30 for monthly tamoxifen or endocrine therapy have been shown to be a deterrent for many women to fill their prescriptions for a drug that we know is life-saving for women with breast cancer.
No, I mean, it has been said that it makes absolutely no sense to have copays for drugs that improve survival, because there's a huge cost to society, of course, when there's premature death, not to mention all the costs taking care of people. And, the copays just are a deterrent. No, it's incredible. So can you count on patients telling you about this?
So much of my work has looked at this, and the data is quite clear that there remains a stigma and shame around asking for financial support. what happens in reality is that there is a subset of women that recognize a diagnosis. They will struggle to pay for care, and they're identified by the health system as being at risk. And we offer them resources early, or they ask for resources early. There is the other extreme of individuals with no financial concerns, but for many people, they believe they don't have financial issues, or we as a health system don't identify that they might struggle to pay for care. And most people don't reach out until they're in crisis. One of our social workers recently reported to me that a patient called her finally when she had $100,000 of debt related to her diagnosis. And so my goal with my science is to help take the stigma away from asking for help and to tell all patients with cancer about the resources we have both within and outside of the healthcare system.
The other day I was talking to somebody who is involved with what's called the Tommy Fund, which is a group that raises money for pediatric cancer. And much of their funds, I believe, are directed to help support patients in almost any way possible. And he was describing a family where the refrigerator stopped working and they were trying to store medicines for their child that needed to be refrigerated. And, what they did at that time was just bring a refrigerator into the house, but not everyone will have the connections to be able to take advantage of programs like that.
That's right.
And it's just horrific. And I think the problem of pediatric cancers is even in some ways more pressing because, of course, there's the need for a parent who may be the wage earner to be ever present.
That's right. And a need to travel for care.
I imagine the other issue is that not only is there some shame associated with not being able to pay your bills, but some patients may just not want to talk about something that they think of as wasting their doctor's time. They want to talk to you about what surgery they should have and, what's happening after surgery in terms of the wound healing and what have you. And I think there's a fear that distracting their doctor from that somehow will be a problem.
So many patients feel rushed during their doctor's appointment, and many physicians, for better or worse, rush patients through their appointment. The key message we need to send to patients and families is that we are here to take care of the whole person, and we have a team behind us to do that. So if you don't want to use time with your doctor to talk about other non-cancer related issues, we have extraordinary social workers, psycho-oncologists, case managers, financial navigators who can support our patients in other areas of their lives to get through treatment in the way we recommend.
Yeah, no, and there are resources out there. I mean, I'll give a shout out to a group called Infinite Strength that was started by someone locally here, although it has a national reach. And it is specifically focused on providing direct support to women who have metastatic breast cancer and are single moms. But one of the challenges, that's a relatively niche area. So we need it for really everyone. Well, we're going to have to take just a very brief break, and we will be back in 1 minute, and we will continue our conversation with Rachel Greenup, professor of surgery at Yale School of Medicine.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where nationally renowned breast cancer specialists deliver compassionate, cutting-edge care. Learn more about innovative treatment options at smilowcancerhospital.org. There are over 16.9 million cancer survivors in the U.S. and over 240,000 here in Connecticut. Completing treatment for cancer is a very exciting milestone, but cancer and its treatment can be a life-changing experience. The return to normal activities and relationships may be difficult, and cancer survivors may face other long-term side effects of cancer, including heart problems, osteoporosis, fertility issues, and an increased risk of second cancers. Resources for cancer survivors are available at federally designated comprehensive cancer centers, such as the Yale Cancer Center and its Milo Cancer Hospital, to keep cancer survivors well and focused on healthy living. The Milo Cancer Hospital Survivorship Clinic focuses on providing guidance and direction to empower survivors to take steps to maximize their health, quality of life, and longevity. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again, and welcome back to the second half of Yale Cancer Answers. I'm Eric Weiner, and tonight we're talking about the financial toxicities and challenges associated with breast cancer treatment and more generally cancer treatment. I've been speaking with Dr. Rachel Greenup, professor of surgery at Yale School of Medicine, who has conducted and is conducting research in this area of financial hardship. So, Rachel, maybe we can talk a little bit about some of the research that you're involved in and some of the early findings, and tell us a little bit about what you're doing.
So I've been studying financial toxicity now for almost 10 years, and I describe myself as a mixed methods health services researcher. I really aim to improve health equity through high-value care and to provide just right treatment for the patients in front of us while preserving resources for the cancer population as a whole. My early work really looked at how women make decisions for surgery and whether financial impact or consequences inform their surgical choices. And we found that many women are thinking about costs, but they're not talking to their medical team about them. That women who are extremely impoverished, so those making below the poverty level, less than $35,000 per year, care more about financial security than even keeping their breast. We spend a lot of time talking about the cosmetics of the breast, where the scar is going to be. And for many women, keeping food on the table is actually their priority. We also found that choice for double mastectomy, which has become a growing phenomenon for women in the United States in the last 20 years, is associated with a higher risk of financial toxicity as well as a greater risk of employment disruption, meaning that the time it takes from start to finish pulls women out of work and they earn less money and they miss opportunities for professional promotion. We had women report that they paid upwards of $45,000 out of pocket for their care. They took out second mortgages, they borrowed from friends and family, and that nobody on their healthcare team talked to them about this. And the unexpectedness of the financial burden made it very difficult for them to plan. So women really want to know what's coming, both from a medical perspective, but also how cancer will impact their lives as a whole. And as a healthcare system, we are being reactionary and not proactive in educating patients. This led me to our current study called the Forecast Project.
Can I just jump in for one sec? And I realize that we're not talking so much about breast cancer and we're talking more about financial toxicity. But this whole issue of bilateral mastectomies is one that has been sort of bothersome to many breast cancer doctors for a long time. And there is this increasing phenomena of people choosing bilateral mastectomies. And by all means, we want women to choose what feels right to them. On the other hand, this is typically done not for any really sound medical reason, meaning we're talking about doing these kinds of procedures, not necessarily in women who have a genetic predisposition or who are at particularly high risk of a cancer in the other breast?
So the controversy around double mastectomy has really described women with a breast cancer on one side with a healthy breast on the other side who has decided to remove both breasts. And for the audience, the data is quite clear that removing a healthy breast does not help women live longer. It does, in some cases, reduce the risk of a second breast cancer, but for many women, we're watching them closely, and God forbid that were to occur, we would find it and treat it. And the risk of that is very low, about 0.5% per year. The rate of double mastectomy in young women has gone up over 30% in the last decade. And many young women are choosing this in part for peace of mind, for symmetry with reconstruction, and to really avoid the trauma of hearing they have cancer again. We really encourage women to make choices that work best for their lives, but thinking about the finances and the employment disruption, the numbness, the body image that results is important. And I believe that talking about financial security as a part of this choice is really critical, because women have told me years later they didn't know what they were getting into.
Yeah, no. And, we are all for people making the decisions that are truly best for them. But I think that sometimes all of us are concerned that there are just misunderstandings of the data, particularly in that emotionally charged period of time, whether it's weeks or a month or two when someone's newly diagnosed. And it's so easy to just knee-jerk into a decision that really sometimes needs a little more thought. Anyway, I want to get back to your research on financial toxicity, but I had to sort of, take that detour briefly. So in terms of the present work you're doing, tell us about that.
So we, like all good science, where we are now is a result of trial and error and seeing what worked and what didn't work. And when we learned that finances were a part of women's decisions, but we weren't addressing that component of surgical choice, I tried early in my career to provide women with cost estimates, financial navigation, as well as educational materials about deductibles, co-payments, all the numeric side of financial toxicity. And what we found in a small pilot trial pre-pandemic was that at the time of diagnosis, women are so scared, understandably, after hearing they have cancer, that they can't process this information in a meaningful way. So we shifted gears and started looking at storytelling, whether women hearing from other women might be a more impactful way to learn about the potential of financial toxicity from women who had actually been through it. And the forecast study was really a beautiful collaboration with myself, Dr. Ellie Prasaloglu, Matthew Dix, who's a storytelling expert in West Hartford, Connecticut, and J.H. Artistry, a videographer outside of Fairfield, Connecticut. And we recruited young women who self-reported financial toxicity to participate in 2 storytelling workshops. They then completed a storytelling slam, which was profound and well attended. And then we video recorded a subset of those study participants to share their stories through video. And we're ready to test it in the clinical setting with hopes to reduce the stigma, to open the door for conversation, and to allow for early and upstream support from our social worker and nonprofit organizations. We have partnered with Infinite Strength in this, and we're hoping that we can make a difference for individuals both with breast cancer and eventually with other cancer types.
It is just such a big problem. And I think we're just beginning to scratch the surface here. So, in our healthcare system, we, of course, have situations where we provide in the United States the very best care. And there are other situations where care just isn't as good. And that is often because people don't have access, or because of, apropos what we've been talking about, because of financial concerns, they choose not to take advantage of care. So are there specific groups that are at particular risk of financial toxicity? Or maybe I should rephrase that, or of avoiding care, being distressed because of financial toxicity?
Yes, so the data is quite clear that individuals under 65 who are working age and not eligible for Medicare are at risk. When you tease out that group more specifically, women and minority women are at higher risk. Individuals with hourly wage jobs who don't have employer-based insurance and don't have reliable, secure salaries are at risk. So those are individuals who cannot take leave from work. If they don't work, they don't get paid. There's also data to show that if you're paying more than 30% of your household income towards medical bills, you're at very high risk.
That's a huge amount.
It's a huge amount
of your take-home pay.
Correct. But you can see with the care we provide for many people, that adds up quickly. Programs like Medicaid are critical for providing support for those individuals at greatest risk. And again, nonprofit organizations such as Infinite Strength, there are national organizations such as the Patient Advocacy Group that can provide support and case management for individuals going through cancer.
And there is, of course, as I think everyone is aware, some amount of waste and unnecessary tests in all of healthcare. Wouldn't you just love to eliminate those tests and be able to provide those dollars to these people who really need it?
We waste more in healthcare every year than we spend on educating our children in the public school system. And so there's tremendous waste, and it's really about a third related to administrative complexity, about 25% related to inaccurate pricing, about 20% related to poor care coordination and low value care, meaning that we're over treating people for reasons that aren't entirely explained. 10% is about fraud. And then about 20% is failure to deliver the right care at the right time, which dovetails with low value care. So it's a tremendous amount of waste. And there's a lot of opportunities to educate people within the health system to reduce waste as well.
Dr. Rachel Greenup is a professor of surgical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.